Dr. Daver, what have we learned about TP53-mutated AML, and what is the takeaway for these patients?
TP53-mutated AML remains the most difficult molecular subset of all acute myeloid leukemia. Patients who have this mutation, unfortunately, do not respond well to any of the established standard of care therapies, including intensive chemotherapy, the HMA alone, such as azacitidine or decitabine alone, or even to HMA venetoclax. With all of these, we do see responses, especially with HMA venetoclax and intensive chemo. We can see 50 to 55% remission rate, but the remissions are very short-lived, early relapses, and the median overall survival across all of these currently available standard of cares are between 6 to 10 months. So there has been an intense effort in the last 6-7 years to develop TP53-directed therapies or therapies that will work regardless of TP53 mutation. And there are 2 drugs at this time that are very promising and being evaluated in ongoing phase 2 and phase 3 studies. One of them is an immunotherapy drug called magrolimab, which seems to have very similar activity and tolerability with good response rates in TP53-mutated AML. This has completed a single-arm phase 1b study in frontline TP53-mutated AML, where we saw close to 50% CR/CRi, complete remission rates, and median survival was above 11 months in older unfit TP53, which is better than any survival we have seen in the past in this population. The other study was with a oral targeted therapy towards TP53 called APR, and this therapy was specifically designed to target the TP53 mutation, and this is being evaluated in the frontline setting in combination with azacitidine venetoclax. So we hope that these regimens or these novel therapies, one or both of them, will be able to at least incrementally improve their current outcomes in TP53. The other area where we have really been doing a lot of research, and I think the data is suggesting, is that allogeneic stem cell transplant may work for a subset of TP53-mutated AML, and we are routinely considering transplant in these patients in the frontline setting once they are able to achieve remission. My activation tip is that TP53-mutated AML remains the most difficult subset of all acute myeloid leukemia. There is hope on the horizon with new treatments such as CD47 antibodies and targeted therapies like APR that are being looked at, and also a strong consideration for allogeneic stem cell transplant in TP53-mutated AML, because this seems to be the only modality associated with a good chance of cure after achieving remission with one of the frontline therapies.